Professor Bhatia sir, Chair of Clinical Grand Rounds, our senior faculty members, residents, ladies and gentlemen, it is our pleasure to present this CGR of viral infection and renal transplantation. So this is the overview of, I will present the overview of the infection and renal transplantation, and our residents will present some case scenario and our experiences on the different viral diseases, and finally that would be the take-home messages out of this presentation. We all understand in 70s, Rubens has given one timeline for infections in transplantation, but that was the era when there were no stronger immunosuppressions were available. Now the stronger immunosuppressions are available, and this timeline is changing. But still there are few facts. Between first month to 6 months, the patient is at the highest degree of immunosuppression, and this is the period of the many opportunistic infections, particularly the viral infections like herpes viruses, cytomegalovirus, hepatitis B, C activation, and many other viruses gets activated during this period. So viral infection in renal transplantation, some of the viruses have direct cytopathic effects that can cause virus like the CMV, can have latent activation from the latency, and can cause pneumonitis, nephritis, hepatitis. Recently, COVID virus, which we have seen, the SARS-CoV virus, which have infected the renal tissues directly. Some immunomodulatory effects are there, particularly I'm just telling one example for the CMV, which not only cause rejection, it increases the expression of the MSC2 molecules and can cause rejection. At the same time, they can predispose the patients for the other infections. And all these infections are prone for developing some of the carcinoma, cancers, proliferations, hepatitis B, like hepatocellular carcinoma, Epstein-Barr virus can cause B-cell lymphoma, splenic lymphoma with the hepatitis C, some of the Kaposi sarcoma. There are several things which happens because of oncogenicity of these viruses also in transplant scenario. And the major concern for all transplant physicians are there that majority of the patients are now dying not because of the rejections, not because of mainly because of the infections, and dying with a functioning graft. So that is all concerned. And this is the scenario just published 3 years before from Korean experience, and they have shown 61% of the patients were dying with the functioning graft, not because of the rejection, not because of the loss of the graft. And this is our scenario. In 5 years periods, we have studied 444%. Majority of the patient have one or more infections. And when you look at any patients who had infections, they had always a poor graft survival and poor patient survival. And majority, 30% of the patient has definitely genitourinary infection, 25% pulmonary, and 15% had the GI infections. And out of all these organisms, we can see 57% has a bacterial, 17% patients had the viral infection, 10% had the fungal infections. So this is all scenario of our experience. Now I will invite our resident, Dr. Shubham, to present the case scenario and our experiences. Over to you, Shubham.
Thank you, sir, and good morning, everyone. So I am presenting CMV in renal transplant. So as we know that CMV is a member of the Herpes virus family. It's a ubiquitous virus, which is a seroprevalence of 50 to 80% in the transplant in the adult population. And in the Indian scenario, by the time of the transplant, around 100% of the donors and recipients become seropositive. And 50 to 75% of solid organ transplant recipients, including renal transplant recipients, have evidence of CMV replication post-transplant. So as sir told earlier, CMV being an opportunistic infection was classically seen in the period between 1 to 4 months after transplant. However, the epidemiology of CMV has changed with the advent of effective antiviral prophylaxis and with the availability of newer, more potent immunosuppressive agents. Whereas earlier the incidence of CMV was high, as much as about 70%, and used to occur early after transplant. Nowadays the incidence of CMV has come down to 1.2 to 4%, and the epidemiology has shifted to a later date. So in the Indian scenario, where both the donors and recipients are seropositive at the time of transplant, the CMV mainly occurs as reactivation or a superinfection. So CMV has got both direct and indirect effects. The direct effects include its propensity to cause viral syndromes and also tissue invasive disease, where it can directly affect organs like lungs and the gastrointestinal tract. However, CMV is also an immunomodulatory virus and has got important indirect effects as well. For instance, it can predispose to allograft rejection. It can cause EBV-related post-transplant lymphoproliferative disease, and it can also lead to systemic immunosuppression, which may further predispose the patient to various kinds of opportunistic infections. In fact, we reported two such cases of co-infection with CMV. The first case was a co-infection of CMV with Pseudomonas, where the post-transplant patient presented with fever and ulcers over the axilla, scrotum, and penis. Along with this, there was also graft dysfunction. The culture from the ulcers showed growth of Pseudomonas, and the patient received antibacterial therapy, but there was no improvement in his symptoms. So we went ahead and did a skin biopsy. This showed the presence of nuclear enlargement with viral inclusion bodies. And then we did a kidney biopsy because of graft dysfunction, which also showed the presence of viral inclusion bodies. The immunohistochemistry was positive for CMV antigen. This patient actually improved when we gave him specific antiviral therapy. Here is another case of a co-infection of CMV and Kala-Azar. Now, both CMV and Kala-Azar can present with fever, leukopenia, and thrombocytopenia, and this caused a diagnostic dilemma in our case. The CMV DNA PCR was positive, and he was treated with ganciclovir, but however, his symptoms persisted. So we did a bone marrow examination, which showed the presence of LD bodies. This patient improved after he was given a course of amphotericin B. Here is this case actually demonstrates how the CMV typically presents in our transplant population. Here is a 25-year-old patient who got transplanted in April 2010. He received basiliximab as induction therapy and was subsequently placed on tacrolimus-based maintenance therapy. Then 9 months post-transplant, he developed diarrhea, abdominal pain, and postprandial fullness for 2 weeks. His blood CMV PCR was negative. However, gastric emptying time was delayed. The upper GI endoscopy showed presence of gastric and duodenal ulcers. When we did a biopsy and a histopathological examination, we found out that viral inclusion bodies were present. The tissue CMV PCR was positive, and then he was placed on IV ganciclovir. With this, his symptoms resolved, and there was normalization of the gastric emptying time. There is another case of a 25-year-old patient who got transplanted in January 2011 and received basiliximab as induction therapy. In the peri-transplant period, he had a early CMV syndrome, which presented in form of rise in creatinine and leukopenia, and blood CMV DNA PCR was positive. He was given antiviral therapy and he improved. Subsequently, he was placed on tacrolimus-based maintenance therapy. Then 7 years post-transplant, he developed antibody-mediated rejection. This was treated with heightening of immunosuppression in form of IV methylprednisolone and plasmapheresis. Then later on, 9 years after transplant, he developed late tissue invasive CMV disease in form of chronic diarrhea, and colonic biopsy CMV DNA PCR was positive. So this case demonstrates that a post-transplant transplant recipient had early CMV syndrome, which predisposed the patient to rejection, and following which was treated with heightened immunosuppression, and this in turn predisposed the patient to have late tissue invasive CMV. Here we presented a case series of patients with chronic diarrhea, anemia, and leukopenia, where the GI CMV was suspected, but blood CMV PCR was negative. The endoscopies were normal, and biopsies taken from the normal-looking GI mucosa did not show any evidence of viral cytopathic effect. However, the diagnosis was made on the basis of tissue CMV PCR, which was positive, and this allowed us to diagnose as well as treat the patient. And the symptoms resolved after starting anti-CMV therapy. So this is our center's experience on CMV. This study was conducted on the transplant patients in the period between 2003 to 2009. We found out the mean time to CMV was 7 months. The most common symptoms were constitutional symptoms. The most common compartment involved was the gastrointestinal tract. The most common lab finding was leukopenia. We found out that the incidence of CMV disease was similar amongst those who had received azathioprine and MMF as maintenance therapy. However, the time to infection was more, and the incidence of leukopenia was more in the azathioprine group. Subsequently, we did a comparative analysis of early versus late CMV, as late CMV was found to be more common in our transplant population. We found out that late CMV was associated with a heightened net state of immunosuppression, with greater use of ATG for induction and with the higher use of plasmapheresis. And we've also found out that early CMV tended to present as a CMV syndrome, whereas late CMV tended to present as a tissue invasive disease. I now invite next speaker, Dr. Sarvabhaum, to present on varicella zoster in transplant recipients.
Good morning, everyone. I'm presenting a case varicella zoster in renal transplant recipients. The most common population that is affected with varicella, as we know, are the children. It runs a complicated course in adults and infants with a mortality of around 2.5%. The mortality rate of disseminated varicella zoster in transplant population is high, that is around 30%. The primary infection with varicella zoster causes varicella infection, which has prodromal symptoms with fever, running nose, and cough. There is a pruritic maculopapular rash with polymorphic eruptions, hemorrhagic rash, and vesicular in nature. It has a typical centripetal spread. Herpes zoster is the reactivation of the primary varicella zoster virus, which presents as a painful rash, which is having dermatomal distribution, which does not usually cross midline. And if there is involvement of more than three dermatomes, we call it a disseminated zoster. I'm presenting you a case, which is an interesting case of a renal allograft recipient of May 2009. The basic disease being chronic glomerulonephritis. The patient was on triple immunosuppression, prednisolone, tacrolimus, as well as MMF. The patient developed fever of 100 to 101 Fahrenheit with cough, running nose for 3 days, following which he had back pain for 1 day. There was development of a single vesicular rash over the back. There was no history of prior history of vaccination or prior history of contact to any patient or history of infection in childhood. During the hospital stay, he developed painful vesicular eruptions in the medial thigh bilaterally, which can be shown in the figure, and subsequently he was started on paracetamol and oral acyclovir. Over the course of the stay, he developed polymorphic eruptions, that is maculopapular and vesicular rashes, which spread over the whole body, including face and trunk within 2 days, as we can see in the figure. And the vesicular eruptions were serosanguinous in nature, and the fluid was hemorrhagic. He was started on IV acyclovir and pregabalin. On day 3, he developed sudden onset shortness of breath with hemoptysis, 2 episodes of hemoptysis. As we can see the X-ray, which shows bilateral alveolar infiltrates, he developed pneumonitis. Subsequently, he developed type 1 respiratory failure, mechanical ventilation was started, and over time there was clinical improvement. He was extubated. The skin lesion started healing with scab formation, as we can see in the figure, and the X-ray showed resolution over time. The patient was discharged in stable condition. Coming to concurrence, the simultaneous occurrence of varicella infection with herpes zoster is an uncommon finding. It is probably because of the immediate reactivation and replication of virus without latency in the ganglia, and there was antidromic movement of the virus along the nerve trunks to the skin. This is probably due to the deficient cell-mediated immunity in our patient population, where there was loss of latency in the patient and there was immediate reactivation of the varicella zoster. Our center experience, the publication included 1546 patients from a period of 2000 to 2010, and I have included data from 2011 to 22, where the incidence was found to be 1.5%. The timing of infection post-renal transplant was most common during the first 6 months of transplant. Most of the cases we could find. There was no history of pre-transplant vaccination or exposure, and the most common complication that we noted were secondary infection, mostly bacterial infections. The mortality rate was 8.5%. Although varicella immunization is not covered under universal immunization program, the IAP covers primary immunization, catch-up vaccination, and post-exposure vaccination. In our patient population, ESRD population, if there is history of varicella during childhood or immunization history, then there is no need of vaccination. If there is no history of exposure or vaccination, then vaccination at least 1 month before transplantation has to be ensured, and vaccination of all the family members has to be ensured. Varicella can be given to all non-immune patients and zoster patients aged more than 60 years. Whenever the transplant patient has exposure, if there is no history of immunization or history of varicella during childhood, then there is we have to have post-exposure prophylaxis in the form of acyclovir, valcyclovir, varicella zoster immunoglobulin, and IVIG also. And isolation of and treatment of the family members has to be ensured. The doses has been mentioned. And if there is history of varicella during childhood, there is no active intervention needed. So I would comment that this is a vaccine preventable disease, and I would like to invite Dr. Rachna to comment on VKV virus.
Good morning, everyone. I'll be talking on BK virus in renal transplant. As we all know, BK virus is a ubiquitous DNA virus with a seroprevalence of 80 to 90%. The primary route of transmission of this infection is actually mucosal. After a primary viremia, in an immunocompetent adult, it establishes latency in the kidney and the uroepithelium. In the immunocompromised, in the setting of a dysfunctional cell-mediated immunity, it results in asymptomatic subclinical infection. Now, because it's a subclinical infection, screening is recommended for BK infections in post-transplant patients. The most important risk factors for BK virus are higher net state of immunosuppression, elderly diabetic recipients, ABO incompatible transplants, and ureteric stent placements. The most common presenting feature of BK virus is an asymptomatic rise in creatinine, which causes slow graft injury and then can result in graft loss. In rare situations, it can also result in ureteritis, ureteric stenosis, and graft hydronephrosis, resulting in graft dysfunction. Because immunity is the least in the first 6 months post-transplant, incidence of BK viremia and BKV nephropathy is the highest during this period. Here we report a case of late allograft dysfunction secondary to BKV ureteritis, which resulted in graft dysfunction secondary to graft hydronephrosis. So this image demonstrates presence of proximal ureteric thickening resulting in graft hydronephrosis. After placement of BJ stent, this patient had resolution of hydronephrosis with a stable graft function. BKV can also coexist with other viruses such as cytomegalovirus, which have worse prognostic implications on the graft. Here we looked at graft survival at 1 year, 3 years, and 5 years. This was studied between January 2010 to 2016, during which 6 patients had coexistent BK virus and CMV nephropathy. So here we show that regardless of the infection, presence of BKV in isolation or presence of BKV with cytomegalovirus, outcomes on the graft are poor. The real challenge to the physician comes when on a graft kidney biopsy, we find tubulointerstitial inflammation. So in 3 scenarios, we can have tubulointerstitial inflammation. It can be in BKV nephropathy, it can be in rejection, or it can be coexistence of both rejection and BKV nephropathy. When there is BKV nephropathy, the cornerstone of management is reduction of immunosuppression. And on the other end of the spectrum, when there is rejection, we have to intensify immunosuppression. Now, what do we do when there is both? So the treatment of choice when there is BKV nephropathy with rejection is IVIG. So how do we differentiate BKV nephropathy from acute rejection? The most important findings are presence of SV40 staining on IHC with viral cytopathic changes which favor BKV nephropathy, presence of glomerular inflammation, and C4D staining favor acute rejection. This dilemma was studied at our center between a period of Jan 2010 to March 2021, during which 1149 living donor transplants were studied, out of which 7 patients had presence of both BKV nephropathy and rejection, and we demonstrated graft loss in 3 patients and stable graft function in 4 out of the 7 patients. Presenting a 41-year-old male with basic disease of presumed chronic glomerulonephritis who underwent a living donor transplant, ABO compatible with basiliximab induction, had excellent graft function with baseline creatinine of 1.1. 8 months post-transplant, he developed asymptomatic rise in creatinine to 1.7 over a period of 1 month. Differentials considered were acute rejection, CNI toxicity, BKV nephropathy, and recurrence of basic glomerular disease. So his basic investigations revealed anemia, therapeutic TAC levels, blood BKV PCR of more than 1,35,000. He did not have any proteinuria or active sediments. On the right hand panel here, urine decoy cells were positive in this patient. So we did a graft kidney biopsy which showed extensive tubulitis. Here on close examination, viral cytopathic changes were noticed within the tubular epithelium, and SV40 staining on IHC was positive in this patient. So this patient was treated for both rejection and DKV nephropathy and was given IVIG, and at the end of 6 weeks he had stable graft function with clearance of BK viremia. Coming to our center experience, between January 2011 to September 2022, 1,280 living donor transplants were done, out of which 40 patients had BKV nephropathy, representing 3.1% incidence. Most of them, as we discussed, had asymptomatic rise in creatinine, and 2 patients had graft hydronephrosis. Coming to graft outcomes, all patients, 40 out of 40, had chronic renal allograft injury, out of which 7 had graft loss and 31 had stable graft function on further treatment. And now invite Dr. Gulab to speak on hepatitis C virus in transplant.
Good morning, respected teachers. I'm going to deliver talk on hepatitis C and renal transplant patients. So, hepatitis C virus is associated with glomerular kidney disease, and it leads to the progression of chronic kidney disease to the end-stage renal disease. In dialysis population, it increases the mortality and the morbidity, and in renal transplant patient, it is associated with lower allograft and overall survival. Its prevalence is up to 42% among the dialysis populations in developing country, and its incidence is 3 times higher than the general population. It is mainly acquired through the blood transfusion, or if there is a history of any prior transplantation or any intravenous drug use. Those patients who have a prolonged dialysis vintage, they are more prone to develop this hepatitis C infection in the course. Those patients on dialysis, we screen patients for the transaminitis and anti-HCV antibody, and even a mildest form of elevation of liver enzymes. We have a keep a high suspicion of HCV infection. So we do the HCV RNA. In those who are HCV RNA positive, we screen the patients for the signs of decompensation. And in decompensated patients, the combined kidney and liver transplantation is advised. In compensated cirrhosis patients without portal hypertension, those who have a short time to transplantation, less than 6 months, they are treated after the transplant. But those who have expected time to transplant more than 6 weeks, they are treated before transplantation. In disease donor, they are treated after the transplantation. These patients are followed with HCV RNA 3 months post-transplant and proteinuria every 6 months. In post-renal transplant, the HCV infection increases the risk of acute rejection, new onset diabetes, proteinuria, thrombotic microangiopathy, and de novo glomerulonephritis. Although the post-renal transplant patients, the progression of hepatitis has not yet been fully understood, but the risk of developing chronic hepatitis is higher among the tacrolimus group. Several studies have shown that in dialysis populations, the overall survival at 5 year and 10 year is equivalent both in HCV positive and HCV negative patients, but the adjusted hazard ratio for the mortality is higher in HCV positive patients. In post-renal transplant patients, the rate of the death rate is higher among the HCV positive patients compared to the HCV negative. Although this study from our center has shown that the long-term outcomes is equivalent both in the patients for the graft and the overall survival. Here is a case of 31-year-old male who was on dialysis since 2013. He acquired infection during the dialysis, and he was managed with pegylated interferon and ribavirin for 6 months. He achieved the sustained virological response. In the pre-transplant workup, he was worked up for the signs of decompensation. So he underwent the live-related renal transplantation, induction given being ATG, and he was kept on triple immunosuppression. But on day 6, he developed transaminitis. So we have done the HCV RNA, which was elevated. So he was started on the direct antiviral agent, so sofosbuvir and ribavirin, and he achieved SVR after the 12 weeks of therapy. 3 years post-transplant, he was admitted with the acute graft dysfunction, and his urine routine microscopy showed the proteinuria of 2+ with bland sediments, and 24-hour urinary protein shows 1.2 gram protein. So after eliminating all the possible causes, we kept the possibility of acute rejection or de novo occurrence of glomerular disease. So a graft biopsy was done, and it shows the antibody-mediated rejection. So he was managed with IV methylprednisolone, intravenous immunoglobulin, and plasmapheresis. He was discharged with a serum creatinine of 1.8. In 2020, he developed the chronic diarrhea. He was treated with ganciclovir because it was found out to be a CFB colitis. In January 2021, he developed severe COVID pneumonia. So his immunosuppressions were modified, and later on he developed the graft dysfunction, and he was counseled for renal replacement therapy. Currently, he is on maintenance hemodialysis. So, before the advent of direct antiviral agent, the standard of therapy were ribavirin and interferon. But the problem with these drugs is they were poorly tolerated. There were more risk of graft dysfunction or acute rejection, and there is also more risk of relapse after stopping the treatment. So, this direct antiviral agent have revolutionized the treatment of hepatitis C in the post-transplant patients, and we treated 22 post-transplant patients with ongoing viral infections with direct antiviral, and all of them have achieved the 100% sustained virological response. So, in accordance with the KDO and international European and American guidelines, they have advocated the use of pangenomatic direct antiviral agent for patients with hepatitis C infections in chronic kidney disease and in transplant patients. Now, I would like to invite Dr. Mayer for speak on hepatitis B.
Good morning, everyone. Hepatitis B infection has a complex relation with the kidney diseases. It can cause glomerular diseases via immune-related mechanisms and can lead to worsening of the kidney disease because of the exacerbations of the metabolic complications. It has been seen to be associated with an increase in mortality in CKD and renal transplant recipients. With the use of antiviral agents, caution has to be exercised, as in patients with deranged RFT, there are drug interactions and dose adjustments have to be seen. With the advent of hepatitis B vaccination, the prevalence in the CKD population has gone down from 46% to 1.3%. In the renal transplant recipients, the prevalence has decreased from 21% to 9.2%. The other factors for the decrease in prevalence of hepatitis B infection are the better screening of the blood products for the hepatitis B and hepatitis C infection, the strict implementation of the infection control measures, and the reduced transfusion requirements with the erythropoietin stimulating agents. Presenting a case of a 43-year-old male who was declared end-stage renal disease in 2008. He was non-compliant to the complete regimen of the hepatitis B vaccination. As part of the routine monitoring in our dialysis unit, he was diagnosed to have HBs antigen positive status. His anti-HBC IgM was positive. HBV DNA was detected to the tune of 8870 international unit per ml, and there was mild transaminitis. And a diagnosis of acute hepatitis B infection was kept, and patient was started on entecavir, which he was told to take post-dialysis weekly. Simultaneously, he was also being worked up for ABO-compatible renal transplant, and his donor status was confirmed as negative. Prior to the transplant, his HBV DNA was undetected, and there was no transaminitis. In the immediate post-transplant period, he had a rise in creatinine from POD6. His tacrolimus levels were elevated, and there was mild transaminitis. Possibility of calcineurin inhibitor toxicity versus acute rejection was kept. The HBV reactivation was ruled out as HBV DNA levels were repeated and they were undetected. The graft dysfunction and transaminitis resolved with the gradual reduction in the tacrolimus dose. Entecavir was changed to talbibudine 600 mg OD, as it has been seen to be associated with the better long-term preservation of the GFR. Patient was discharged with a creatinine of 1.2 and normal liver enzymes. Post-transplant 4 months, he presented with the progressive weakness of both the lower limbs with difficulty in climbing stairs. On examination, there was no obvious atrophy or hypertrophy of the muscles. There was grade 4 PAR in the bilateral hip flexors. There was no sensory loss, and the deep tendon reflexes were preserved. A clinical impression of proximal myopathy was kept, and the etiologies being considered were the drug-induced, endocrinological causes, inflammatory muscle diseases, and viral infections. As fasting blood glucose of our patient was 88 and TSH was 3.4, so PTDM and hypothyroidism was ruled out. The creatinine phosphokinase levels were not highly elevated. There was no history of rash, and the patient was already on immunosuppressive agents. So the possibility of inflammatory muscle disorders was also ruled out. He did not present with the typical viral prodrome. There was absence of leukopenia, thrombocytopenia, and HIV ELISA was non-reactive. So viral infections was also ruled out. Patient had respiratory rate on a higher side with normal saturation and normal chest X-ray imaging. ABG analysis was done, which revealed high anandamide metabolic acidosis with elevated lactate. However, there was no associated renal dysfunction. There was no hypotension. Hemoglobin was 11.4. Urine ketones were negative, and there was no recent exposure to the alcohol. Electromyography, however, confirmed the myopathic pattern. So, after ruling out the possible causes of myopathy, a likely diagnosis of telbutine-induced myopathy and lactic acidosis was kept. Talbubutine was changed to tenofovir alafenamide, and in the follow-up, the power in the hip flexors improved, and lactate and CPK levels were declined to the baseline value. The mortality outcomes in the dialysis population are higher when compared to the renal transplant recipients. The annual death rate in the dialysis patient is 16.5 as compared to 1.2 in our renal transplant recipients. And with the hepatitis B infection, there is a 35% increase in mortality if these patients they develop liver disease. Before the nucleoside agents have come into the picture, the 80% of HBs antigen positive renal transplant recipients would develop the chronic liver disease, and 57% of the mortality in these patients was attributed to the liver related complications. With the advent of nucleoside agents, there has been a significant improved patient survival with no difference in those who are HBs antigen positive or those who are versus to those who are HBs antigen negative. With the use of immunosuppressive therapy, there is a risk of hepatitis B reactivation in renal transplant recipients to the tune of 22.4%, and they also carry the risk of having worrisome complications like fibrosing cholestatic hepatitis and hepatocellular carcinoma. The major goals in the pre-transplant evaluation of an HBs antigen positive patient is the prevention of de novo infection and reactivation. And after HBs antigen positive status is confirmed, we need to assess for the severity of liver disease. If these patients are found to have decompensated liver disease, they are counseled for combined liver kidney transplant, while those with the compensated cirrhosis can go for isolated kidney transplant, but antiviral prophylaxis is continued for indefinite period. While those with anti-HBC positive and HBs antigen negative can also go for isolated kidney transplant. Antiviral prophylaxis is usually not required in these patients, but monitoring is required for a minimum of 1 year post-transplantation. Our experience ranging from the last 20 years had 65 patients who were hepatitis B surface antigen positive, 5 developed post-transplant reactivation. There were 3 patients with the compensated cirrhosis. When compared with the other studies, the patient as well as the graft survival in our study was comparable, and the major cause of death in our patients was the infections. The hepatitis B is a vaccine preventable disease. In our hemodialysis unit, there is a strict adherence to the universal precautions. An isolated area specially designated for carrying out dialysis of HBs antigen positive patients. And in renal transplant recipient, we regularly monitor anti-HBs titers and liver enzymes, and this is especially required when heightened immunosuppression is done. Now I invite Dr. Nidhi to speak on dengue and renal transplantation. Thank you.
Good morning. We know that dengue is an arthropod bion virus, and we live in an endemic country where 50 million dengue infections annually in 2.5 billion people living in endemic countries. Our renal transplant patient, their age, period after transplantation, and immunosuppressive profile has no effect on disease severity, mortality, or graft dysfunction. Comparing to renal transplant patient, our patient has less of constitutional symptoms but more of serositis, more of graft dysfunction, and the mortality is 3 times than that of general population. During the 2010 outbreak, our patients were also infected with dengue virus. Out of them, 8 had dengue hemorrhagic fever and dengue shock syndrome. They presented with pleural effusion, anemia, thrombocytopenia, transaminitis. 3 out of 8 required need of dialysis, and 3 out of 8 succumbed to death. In 2017, there was a systemic review of literature where dengue fever and renal transplant patients were compared, and 11 studies were taken in where the diagnosis, the outcome, and the clinical characteristics were compared with general population, and their results were similar to our case presentations. Coming to a 49-year-old male who had diabetes mellitus since 2001, hypertension since 2005, he had diabetic kidney disease and underwent ABO-compatible renal transplantation as brother donor, and he was maintained on triple immunosuppressant. In November 2018, admitted in KTU for fever, myalgia, and retroorbital pain, and he had serositis during presentation. On investigation, he had anemia, thrombocytopenia, moderate renal dysfunction, and transaminitis, with viral serology being positive. On day 2 of admission, he developed retroperitoneal hemorrhage followed by dengue shock syndrome, and due to deranged graft dysfunction, he was initiated on dialysis. But on day 9, he's come to death secondary to multi-organ renal dysfunction. This is very unfortunate that a preventable disease is a cause of mortality in our renal transplant patient, which can be prevented by personal protection like mosquito repellent and mosquito control. Though the vaccination is available in many of the countries, but it is in live attenuated, and hence our renal transplant patients are not being benefited. Discussing all the viruses and leaving novel COVID virus will be unbiased because our patients are more susceptible to infection and higher mortality. During the pandemic, we had some unanswered questions and challenges like what were the long-term consequences of higher dose of steroid? Could these patients have been managed safely at home? What would be the efficacy of vaccines in our patient? And how different is the quality of life in our patient? Before this, a 37-year-old male who had hypertension and chronic kidney disease in 2010, he underwent ABO-compatible renal transplantation as wife donor. He received basiliximab as an induction therapy and was maintained on triple immunosuppressant. Post-transplant, he developed new-onset diabetes after renal transplantation. In May 2021, he developed severe COVID-19 infection and was admitted to our Rajdhani Corona Hospital, requiring high-flow oxygen and intermittent non-invasive ventilation. His prednisolone was changed to high-dose IV methyl prednisolone. His mycophenolate mofetil was stopped. During the day 4 of admission, he developed altered sensorium, decreased urine output, and graft dysfunction with ketoacidosis. He was treated with IV fluids, insulin, and IV antibiotics, and subsequently he improved. But on day 9 of admission, he developed left-sided facial puffiness and underwent NCCT paranasal sinus, suggesting fungal rhinosinusitis. On day 15, he underwent left maxillary sinus debridement and developed oroendral fistula. Currently, he has normal graft function. He is on long-term antifungal prophylaxis, but had significant long-term disability. According to recovery trial, the recommended dose of steroid was dexamethasone 6 mg or equivalent. But how will it affect the long term of our patient? For this, we analyzed the long-term outcome of high-dose steroid and low-dose steroid in the 251 renal transplant patient, where 23 had received high-dose steroid, and it was seen that the infectious and non-infectious sequelae were significantly high in high-dose versus standard-dose fungal infection. And 4-week mortality in COVID-19 affected renal transplant recipient by multivariate Cox regression analysis suggested that it was 5.7 times than the dose of standard dose steroids. When coming to outcomes, the readmission rate, fungal infection, lower respiratory tract infection, and post-COVID lung sequelae were more in high-dose steroid as compared to standard dose steroid. ICMR advises that all patients of renal transplant should be admitted to hospital even if they had the mild COVID-19 infection. But due to inpatient overwhelming in our hospital, could this patient would have been managed safely at home? For this, 94 patients were compared with 55 patients who were being hospitalized, and it was seen that the primary outcomes was almost similar. So it was concluded that home-based self-monitoring strategy through telemedical care, which was given by a consultant and resident during the COVID pandemic, resulted in similar outcome as that of inpatient management of renal transplant recipient with mild COVID-19. We all know that the prevention is better than cure, and vaccine is a safer way to build protection against COVID-19 and diminish the severity of disease. But our patients are different because they are immunosuppressed population, and would these indigenous vaccines, especially Covishield and Covaxin, will be successful or not? For this, we took 222 renal transplant patients, and they were divided into 3 groups. One group who had infection, the other who received vaccination, and the third who had vaccination and infection. It was seen that the mean antibody titers were more in vaccination and infection group, and their seroconversion was 95%, while the patient who had only infection, the seroconversion rate was 90%, and the patient who received only vaccination, the seroconversion was 70%. To prevent the biasness of our result, we took the 370 renal transplant patient from 2 centers. One was our center and the other from Medanta, and 2 doses of Covishield and Covaxin was given. And it was seen that the overall seroconversion in Covaxin and Covishield was almost 80%, which was much higher than messenger RNA, which was being available in Western country, where the seroconversion was 60 to 70% in Western population of renal transplant. The quality of life was severely affected in general population and in renal transplant population. So we did a patient reported outcome, where European quality 5D components were being studied, and it was seen that the main component which was affected in our patient were anxiety and depression, hence reducing the significant quality of life reduction. So to compile in all, viral infections are common and important cause of morbidity and mortality in renal transplant recipient. The late CMV disease may be compartmentalized and tissue invasive disease can occur without CMV viremia. BKV nephropathy may cause graft loss and mimic or coexist with acute rejection. Therefore, high index of suspicion should be necessary. Varicella vaccination in CKD population can prevent morbidity and mortality of varicella infection in renal transplant recipient. Direct acting antiviral is safe for hepatitis C virus infection in transplant patient and can eradicate the virus. The early institution of hepatitis B vaccine prevents morbidity and mortality. Hepatitis B virus in renal transplant recipient require prolonged treatment, ideally lifelong post-transplant. Dengue in renal transplant recipient is usually benign, but if they present with dengue hemorrhagic fever and dengue shock syndrome, they may have high mortality comparing to general population. Severe COVID-19 in renal transplant recipient may be fatal and has high mortality than the general population. However, vaccine can prevent it. This is a vaccination card which we provide to all our renal patients who present to OPD, and it includes hepatitis B vaccination, chickenpox, pneumococcal influenza, and COVID vaccination. Our department would like to acknowledge the Department of Urology, Anesthesiology, Microbiology, Pathology, Critical Care Medicine, Radiology, Gastroenterology and Hepatology, Pulmonary Medicine, Endomedicine, Neuromedicine, Transfusion Medicine, and all our patients who believe in us, our lab technicians, our staff who are involved in renal transplant program. Thank you for listening. We are open for discussion.